So we know this global trend of spine surgery is increasing, and I think is the most progressive branch of orthopedics and neurosurgery going in together. So as one does more and more primary, more revisions to turn up. An increase in elective spine surgery has made it as high as 12.5% revision happens. Now, the setting of adult deformity, it relates to a lot of complications in revision, prolonged hospital stay, lesser satisfaction rates. And of course, various articles from all these people mentioned various syndromes like post-splenectomy, failed backs, chronic pain syndromes, and persistent spine syndromes. Now, look at all the various surgeries done. You have laminectomy 10.7, open discectomy 10.5, endoscopic discectomy 9.2, and 7.58% following fusion surgeries. So that's the amount of revision needed. Now, when you look at indications for revision surgery, look at early instrumentation failure, residual stenosis, surgical site infection, CSF leak, hematomas, and late you have instrumentation failure, recurrent pain, adjacent segment degeneration, pseudarthrosis, and flat back fusions. Now, these are again well talked about in terms of ASDs. I don't think I'm going too high into that. So evaluate the patient carefully and take history, assess the pain generator, do an X-ray, CT scan, MRI, and DEXA before putting a knife back again. Now, what are the deciding factors decide whether you want to do an anterior or posterior? Nature of previous surgery, spinopelvic parameters, and most importantly, surgeons' training and protocols. Now, a brief algorithm on what we do. When it's posterior, you have dural injury, paraspinal injury, direct decompressions. When you have direct lateral, antro-lateral, and anteriors, these are the various things you're going to have in terms of responses. So why not posterior again? So working on a scarred area, more blood loss, anatomy is altered, dural tear, neural irritations, and of course when you want to revise the fusion, you got smaller footprints, which makes it much more difficult. So can we go ahead and do something else different in terms of an anterior? So how does an indirect decompression work? When you do an OLIF, the early effects are such as the annulus, corrects the listhesis, and also releases the facet joint. The later effects, atrophy of disc and annulus, and of course, leads to larger fusion rates. So when you look at advantages of OLIF in revision surgery, there's no risk in dural injury, no violation of paraspinal muscles, easier access to remove previous TLIF cages, larger footprints, 3 times the size of the TLIF cage, better fusion rates, and better correction of deformity. So a couple of cases here to show it. Our technique in doing this, I use a 5 centimeter incision, standard OLIF technique where you put in a jig, correct across. I also do surgery without the jigs by using just a Hohmann retractor. Now an algorithm for doing this, again, a previous decompression alone, 1 or 2 lines. This gives a classification status. Go into it where you can have type 1, type 2, type 3 cases here where anterior surgery is proposed. Now this is an adjacent segment degeneration where I've done posterior, came in, had a laminotomy on the level where a simple single stage anterior anterolateral fixation can be done. OLIF, I supplement the OLIF by doing an anterolateral instrumentation itself rather than doing a posterior surgery again. Now this is a lady who had a posterior decompression instrumentation done, failed, and came back with a pain, and we revised to a 3-level OLIF for this patient. So OLIF has a definite advantage. Anterior definitely has a major advantage in terms of revision surgery, and I think if I were to I would go through a virgin territory rather than going through a revision scarred area, and hence I would suggest anterior being the go-to surgery for any revision surgery. Thank you.
Thanks for keeping it short and sweet.